In this session, I am aiming to give an overview of epidurals on ITU. For many doctors, particularly non-anaesthetists, ITU will be the first time that you're expected to manage patients with an epidural with catheter in situ. I'm intentionally not going to dwell too much on the technical aspects of catheter insertion, since by and large patients will come to ITU with the epidural having been inserted by an anaesthetist in theatre. Instead, I mainly plan to focus on aspects relevant to all doctors looking after such patients. In particular, how epidurals work, how they are routinely managed, how to troubleshoot issues with them, and the approach to potential serious complications which can result from their use. This is, of course, an introduction, and you will need to undergo further supervised practice before managing an epidural independently. To start with, we need to think a little about anatomy. As its name implies, the epidural space is a potential space within the spinal canal which lies outside the dura mater, the relatively tough outermost layer of the meninges. Posteriorly, it is bounded by the even tougher ligamentum flavum, which runs between the vertebral laminae. If you have ever done a lumbar puncture, these layers are the ones that you feel give way just as the needle enters the subarachnoid space. The space itself contains a mixture of adipose tissue, fibrous tissue, and a dense venous plexus. Importantly, spinal nerves must transit this space as they pass out towards the intervertebral foramina. Thus, if a drug such as a local anaesthetic is infused into this space, it will bathe these nerves and be able to exert an effect upon them. Epidural anaesthesia or analgesia involves the use of a fine plastic catheter to infuse drugs into the epidural space. The precise effects of this will vary depending upon the drug used and the concentration. Blockade of sensory fibers will cause analgesia, i.e. pain relief, at lower doses, progressing to anaesthesia, i.e. a total lack of sensation suitable for surgery, at higher doses. Associated with this, there will be a blockade of the sympathetic nerve fibers, generally leading to warm, vasodilated peripheries and potentially a drop in blood pressure. Finally, at high doses, a motor block can be achieved, leading to a temporary lower limb weakness or paralysis. This graduated response in each modality is important, since by and large we want to achieve analgesia while maintaining a reasonable blood pressure and a relatively normal motor function. Indeed, with a suitably dosed regime, it is perfectly possible for patients to mobilize with a running epidural. The sensory level achieved is not purely dependent upon the level at which the epidural is inserted, since the local anaesthetic spreads up and down through the epidural space. Higher volumes and flatter or head-down positioning of the patient will encourage the local anaesthetic to spread upwards, and a higher block will be achieved. Therefore, it is perfectly normal for a lumbar epidural to achieve a sensory block corresponding to a thoracic dermatome. Epidurals may be used alone to provide surgical anaesthesia, and this is most frequently seen when a labour epidural is topped up for a caesarean section, but many other lower limb and abdominal procedures can in theory be performed with this technique. More often, however, epidurals are used for that analgesic effect. Again, many of you will be most aware of this in the context of labour analgesia and obstetrics, but this isn't usually all that relevant to us on ITU. Instead, we tend to see epidurals used to provide intra and post-operative analgesia. In Northampton, this will usually be elective major abdominal surgery, such as AAA repairs, gynae cancer resections, or bowel cancer surgery. You may also see epidurals placed for other acutely painful conditions, most notably complex rib fractures. In other hospitals, you will see epidurals used for thoracic and upper GI procedures, such as lung resections and esophagectomies. In most cases at Northampton, the epidural will be inserted at a mid to low thoracic or lumbar level, depending upon the level of block required for surgery. To explain why these patients might benefit from an epidural, let's think about what we are trying to achieve for them by the time they leave critical care. Broadly, we want them to be physiologically stable, alert, infection-free, engaging in rehabilitation therapy, and consuming something close to a normal diet. A patient who is in pain is going to struggle to achieve many of these things. They will have an exaggerated stress response to surgery. They might develop a delirium. They won't be able to cough or take deep breaths to avoid a chest infection. They aren't going to let the physios let them get out of bed, and they won't be keen to eat. All of these issues are exacerbated by the fact that many of these patients will be older and often have a range of comorbidities. In terms of systemic analgesics, this sort of severe pain is only really going to respond to reasonably high doses of opiates, but these are often counterproductive when it comes to our objectives, causing delirium, drowsiness, respiratory depression, dizziness, nausea, and constipation in their own right. In contrast, an appropriately functioning epidural can provide very targeted analgesia with relatively few side effects by delivering local anesthetics and other drugs directly onto the nerves transmitting the pain stimulus. The real take-home message here is that although it might seem tempting to simply scrap a troublesome epidural and switch to a PCA, there are concrete advantages to putting the effort into getting it working where possible. Having said that this isn't a session on epidural insertion, it is useful to have a rough idea of the process, as this provides some context to issues that can develop once the patient reaches critical care. The space is accessed using a blunt-ended TUI needle, which is slowly advanced while trying to inject saline through it using a low-resistance syringe. It is not possible to inject into a dense ligament, but as the tip of the needle enters the epidural space, injection suddenly becomes very easy. This is termed the loss of resistance. At this point, the anaesthetist stops advancing, makes a note of how deeply they have inserted the needle beneath the skin, and threads the catheter through the needle into the space. They then gently thread the needle back over the catheter, which is left behind. The final step is to gently pull back the catheter until the desired length is left behind in the epidural space. On the anaesthetic chart or epidural proforma, you will see the anaesthetist usually documents the depth at which loss of resistance occurs, and either the length of the catheter at the skin or the length of the catheter within the epidural space. Generally, anaesthetists will aim to leave 3.5 to 5 centimeters of catheter in the space. Any more, and they have a tendency to curl or thread out to one side through a foramen, while too little means that the holes along the distal end of the catheter will lie back within the ligaments rather than the epidural space, and no drug is delivered through them. The length marking seen at the skin is the sum of the depth of the space and the length of the catheter in the space. So if the anaesthetist advanced the TUI needle 6 centimeters and wants 4 centimeters in the space, they will secure the catheter at the 10 centimeter mark. There are a number of tests that the anaesthetist can perform to help confirm that the catheter is sitting safely in the epidural space. Firstly, they can look for the meniscal drop. Because the epidural space is at a relatively low pressure, the saline in the catheter will flow inwards if the proximal end is held up in the air above the insertion site. Next, they can aspirate with a syringe. If the catheter is threaded into one of the many veins in the space, then blood will obviously come back, while freely aspirated warm, clear liquid suggests that they've gone too far and are in CSF. Finally, the anaesthetist can deliver a small test dose of local anaesthetic. They will expect to see gradual onset of analgesia associated with a drop in blood pressure over 10 to 15 minutes. No effect suggests that the catheter is outside the space, while a very rapid, pronounced onset indicates that the catheter is in CSF in the intrathecal space. It is possible for a catheter to be left in the intrathecal space. However, in the unlikely event that a patient were to be brought to critical care with one in situ, then it should only be managed by an experienced registrar who personally delivers any top-ups. When a patient arrives on critical care with an epidural, it should look something like this, secured to the skin with a locking adhesive dressing. Make a note of the length of the catheter at the skin. There are blue markings at 1 centimeter intervals, with 2 marks at 10 centimeters and 3 at 15, so the easiest way is to count back for the 10 or 15 centimeter mark. Double check this value against the anaesthetic or epidural chart to make sure that the catheter hasn't migrated. There should then be a clear adhesive dressing placed over the entire entry site so that it can be easily visualized. Finally, there will be some sort of strong tape applied around the edges of the clear dressing, as well as a length sticking the catheter to the patient's back as it heads up towards one's shoulder. At the far end of the catheter, you should find a yellow adapter along with a bacterial filter. These should remain attached to the catheter at all times, since introducing infection into the epidural space can have catastrophic results. If at any point you do need to change the filter or adapter, for example if you need to replace the locking dressing after pulling the catheter back, then it should be performed as a sterile procedure with surgical gloves. The filter itself should either have a clean cap applied or be attached to an epidural giving set or pump. Various combinations of local anesthetics and other drugs can be given down an epidural, but at NGH we use 0.1% levobupivacaine with 2 micrograms per ml of fentanyl. This aims to provide a balance of effective analgesia while minimizing motor blockade. Drugs can be administered continuously or intermittently, but most patients will use a patient-controlled epidural analgesia, or PCEA. This consists of a pump with a patient button and a lockout time, just like an IV morphine PCA which you are likely to have managed previously. If the patient is uncomfortable, then they push the button and a bolus of drug is delivered. The pump will deliver a baseline infusion alongside this, which is particularly useful to ensure that the epidural doesn't wear off entirely if the button is not pressed for a time, for example if the patient is asleep. The PCEA should be prescribed on the epidural chart and the drug chart, stating the mix used, the bolus volume, lockout time, and the baseline rate. If your patient is comfortable, then there is not much else you need to do at this point. However, you may be called because the patient is in pain, and you need to use a structured approach to rule out problems. Your first step is to assess the level of block that has been achieved. Do this using a cold ethyl chloride spray and the sharp end of a neurotip, since pain and temperature sensation travel along the same pathways. Test the patient's forearm or shoulder so that they have a reference, and explain that it is the cold or sharp sensation that you want them to focus on. Then work your way up the dermatomes on each side, making note of whether the patient can and can't feel it. Remember, T4 corresponds to the nipples, T6 to the xyphosternum, and T10 to the umbilicus. Compare each side in turn. You may find that the block is low on both sides, patchy with missed dermatomes, or it is unilateral. For most laparotomies, you will be aiming for a block somewhere around T4 to T6, although double check against the epidural chart. Next, you need to check for any technical issues. Is the pump connected properly to the catheter? Has the length of the skin changed? Or does fluid appear to be leaking from the insertion site? If any of these are a problem, contact a senior to review the patient and see if the situation can be retrieved. Unfortunately, if a catheter has migrated outwards, it is not possible to advance it again, so it may be that the epidural is no longer usable, but a senior should confirm this before giving up on it entirely. Has the patient actually been pushing the button? If not, encourage them to do so and explain that it will generally take 15 to 20 minutes for them to start seeing benefit. If the block is low, try lying the patient a little flatter, and if unilateral, try to lie the patient on the unaffected side, as this may encourage local anesthetic to migrate in that direction. Whatever the pattern, give a 5 ml clinician bolus via the pump and reassess after 15 minutes. If there has been some improvement, it's worth repeating this a couple more times, since an epidural sometimes needs to achieve an adequate volume to really start working. Make sure you check the level each time and stop if the level is above T4, or if the patient begins to show any signs of hemodynamic instability or breathing difficulties. If the block is now adequate, discuss with the senior regarding increasing the baseline rate to maintain this. If the block remains unilateral, the catheter may have threaded out to one side, so it might be possible to gently withdraw it 1 centimeter to bring the tip back to the midline. This should be done as a sterile procedure under senior supervision before a further bolus is given and the block checked again. At the opposite end of the spectrum, you may find that an epidural is working too well. In the early stages, this may simply manifest itself as a high sensory level above the nipples, but can progress to cause respiratory muscle weakness or cardiac sympathetic blockade, with bradycardia, hypotension, or arrhythmias. If the patient is showing any signs of physiological instability, pause the epidural infusion, call for urgent senior assistance, and start going through your ABCs. If there is an isolated high sensory level, it may be possible to slow down the baseline infusion or reduce the bolus frequency or volume, but you should discuss this with the senior first. The most extreme manifestation of a high block is a total spinal, which usually occurs if an intrathecal catheter goes unrecognized and a large epidural bolus of local anesthetic is given into the CSF. This causes rapid onset respiratory paralysis, progressing to coma and convulsions. Such patients are likely to require emergency intubation and vasopressor support, so call for senior help immediately. As we've already said, an epidural will block sympathetic as well as sensory nerves, and this leads to hypotension due to vasodilatation. This is often hard to avoid, and in some cases, such as following a AAA repair, can even be helpful. Remember, these patients have undergone recent surgery, so you need to fully assess them to rule out other causes of hypotension in a post-operative patient, such as bleeding or sepsis. If they appear dry, a fluid bolus may improve things, but remember that the main problem is excessive vasodilatation, so starting a small dose of a vasopressor such as metronidazole or noradrenaline is likely to be more helpful. The next issue you may encounter is excessive motor blockade. While some degree of lower limb weakness may be seen with an effective epidural, the low concentration mixes we use mean that this should be mild. More extensive motor weakness may indicate spinal cord or cord requiner compression, either due to an epidural hematoma or abscess. Although both of these complications are incredibly rare, they are neurosurgical emergencies with devastating results if they go unrecognized. If the patient is unable to flex their knee and/or ankle, stop the epidural infusion and reassess after 30 minutes. If there's no improvement in neurology, contact a senior urgently as they are likely to require emergency MRI and transfer to a neurosurgical unit. Remember, we do not have out-of-hours access to MRI in Northampton, so early escalation is vital in case a transfer to another unit is required for imaging. If the weakness improves, the epidural can probably be continued, but discuss with the senior regarding reducing the rate or the dose. A final emergency you may encounter is local anesthetic toxicity. Repeated epidural boluses may lead to an excessive dose of local anesthetic being administered to the patient, especially if the catheter tip migrates into a vein. At first, this may present as a tingling sensation around the lips or a metallic taste in the mouth, but it can progress to coma, arrhythmias, and convulsions. If the patient shows any signs of toxicity, stop the epidural, do your ABCs, and call for urgent senior assistance. They may require intralipid, a fat-rich solution which soaks up the local anesthetic when given intravenously, and this will need to be brought up from main theatres. The ICU or theatre anaesthetic senior will be able to assist with dosing this appropriately and administering it. When the epidural is no longer required, usually after around 48 to 72 hours, it can be removed by gently pulling out the catheter. The catheter has a blue tip, and its presence should be documented to confirm that a fragment has not been left behind, although even if this does occur, it is usually just left in place. One thing it is worth being aware of is timings related to anticoagulants. The catheter should be removed a suitable interval after the last anticoagulant dose, and a further interval needs to be observed before further doses. Intervals vary by drug, so you will need to check these individually, but it can be a particular issue if a patient develops an issue such as a suspected PE, which requires therapeutic anticoagulation. The timing and order of the catheter removal and drug initiation should be discussed with the senior. Finally, let's just go over some key take-home points from this video. Epidurals are used on critical care to promote patient comfort and recovery from major surgery. They are usually safe and effective, but sometimes need some troubleshooting. If they are not working effectively, check the sensory level, confirm that the tip hasn't migrated, try repositioning your patient, and give cautious boluses. If the patient becomes unstable, stop the infusion and go through your ABCs. You can always restart it later. Don't ignore motor weakness and investigate it urgently if it doesn't improve. Don't be afraid to ask for help. Seniors in ITU, theatre anaesthetist, and the acute pain team are all options if you're unsure what to do.